Hello and welcome to the second part of the patient information sessions on inflammatory arthritis. In this talk, I'll go through the medications which are commonly used to treat rheumatoid and other types of inflammatory arthritis. These are the groups of medications we're going to cover in this talk. So starting with simple painkillers. These are used to treat the symptoms, but will not significantly counter the inflammation or alter the disease process. The three main groups are paracetamol, opiates, which includes codeine and tramadol, and NSAIDs, or non-steroidal anti-inflammatories, such as ibuprofen. They can be used in combination and are helpful for treating newly diagnosed rheumatoid arthritis, as well as managing flares. The NSAIDs include ibuprofen, naproxen, and diclofenac. They're effective at treating inflammatory pain. The main side effects to be aware of are irritation of the stomach lining or kidney problems. They should also be avoided in people who have heart disease and be used with caution if you're taking blood thinner medications because of the extra risk of causing a stomach ulcer or bleed. If taken regularly, they should be taken alongside gastric protection, which is often in the form of omeprazole. Steroids are used commonly in newly diagnosed inflammatory arthritis or in a flare. They're usually given in short courses or as a one-off intramuscular injection. They start working quickly, usually within 24 to 48 hours. When used for long durations, there are a number of associated side effects, which includes weight gain, increased risk of type 2 diabetes, and thinning of the bones. Steroids can be administered in various ways. We can perform joint injections, where the steroid is injected directly into or around the inflamed joint, which provides local treatment to an affected area. They can also be injected into a muscle, which leads to more generalized release and effect. Injections are usually associated with fewer side effects than oral steroids. Conversely, we also use courses of oral steroids, which enables us to gradually taper the dose as your symptoms improve. Side effects are more likely if you are on a higher dose or with longer-term use. The next group of medications I'm going to talk about are the DMARDs, which stands for disease-modifying anti-rheumatic drugs. These work on the immune system to reduce inflammation. In doing so, they also reduce the likelihood of joint damage. The ones that we most commonly use include methotrexate, sulfasalazine, leflunomide, and hydroxychloroquine. As mentioned, DMARDs work by modulating or suppressing the immune system. They take up to 3 months to start working, hence the need for steroids to bridge the gap when starting DMARD therapy. All of the DMARDs, aside from hydroxychloroquine, require blood test monitoring. This is to check the blood count, liver, kidney, and inflammation markers to ensure that the DMARD is not causing any problems. If you develop an infection serious enough to require antibiotics, your DMARD should be temporarily stopped until the antibiotics are finished and the infection has resolved. This also applies to if you get COVID infection. If pregnancy is being planned, it's important to discuss this with your rheumatology team, as certain DMARDs should not be used in the context of pregnancy or breastfeeding. Methotrexate is the DMARD that we usually use first line in inflammatory arthritis. It comes in tablet form, but we also use a subcutaneous injection form for those who experience certain side effects. It's given as a weekly dose and is followed 2 days later by folic acid tablets, which help to reduce the likelihood of side effects. The commoner side effects associated with methotrexate are nausea, mouth ulcers, and thinning of the hair. Other potential risks are oversuppression of the immune system, liver inflammation, or rarely lung inflammation. Blood test monitoring is needed while on methotrexate. Initially, this is every 2 weeks, but after about 2 months, this reduces to monthly and can be extended to every 3 months once you're fully established on methotrexate. Methotrexate can cause fetal problems in pregnancy, and it's therefore important that women of childbearing age use contraception whilst on methotrexate. If you're taking methotrexate and wish to start a family, it should be stopped at least a month before conception and only restarted after birth and breastfeeding is discontinued. Because of the risk of liver inflammation, we recommend limiting your alcohol intake whilst on methotrexate. If methotrexate isn't suitable, doesn't work, or isn't tolerated, then we have several other DMARDs that can be used. Leflunomide is a daily tablet. In terms of side effects, this can cause diarrhea, nausea, and weight loss. It can also cause blood pressure to go up, so this needs to be monitored with its use. Sulfasalazine and hydroxychloroquine are both less potent DMARDs. They're both safe in pregnancy and breastfeeding. With long-term use of hydroxychloroquine, usually more than 5 years, there's a small risk of an eye problem called maculopathy. We therefore refer people for retinal screening after 5 years of use. When your DMARD is started, you may hear the term shared care agreement. This is an agreement between the rheumatology team and your GP regarding the prescription and monitoring of the DMARD. For the first 2 months or so, the rheumatology team provides the prescription and monitors the blood tests. Thereafter, assuming everything is stable and there are no issues, the GP will continue to prescribe and monitor the medication. The doctor or nurse will need to check the monitoring blood test before issuing the next prescription. For some people, maybe around 10 to 20% of people with rheumatoid arthritis, the disease is more aggressive and more difficult to get under swift control. But a range of injectable biologic drugs, which includes biosimilars, have revolutionized treatment for people who don't respond to standard DMARDs. Biologics target specific parts of the inflammatory pathway, and there are a number of different types. You may also hear about the biosimilars, which are biologic drugs made after the patent of the original biologic expires. They're essentially the same as the original product, but they're more cost-effective. The different types of biologics include anti-TNF, of which etanercept and adalimumab are the most commonly used. There's subcutaneous injections, usually given every 1 or 2 weeks. Rituximab is an intravenous infusion given as 2 infusions 2 weeks apart and then repeated every 6 to 12 months. Tocilizumab can be given either as a subcut injection or monthly intravenous infusion. And JAK inhibitors are newer medications in the form of oral tablets. If you have an inflammatory arthritis such as rheumatoid arthritis, you can be more vulnerable to infections, and therefore it's generally recommended that you stay up to date with the seasonal vaccinations such as flu and pneumococcal vaccines. In general, live vaccines should be avoided when you are on DMARDs or biologics. This is because live vaccines contain weakened versions of a virus or bacteria that can potentially cause infection in those who are immunosuppressed. However, there may be exceptions to this, such as being on the milder DMARDs, so it's always worth checking with your rheumatology team. For those on DMARDs, you may also need to take precautions around close household contacts who receive live vaccines. The shingles vaccine is now non-live and can be safely used in those on DMARDs or biologics. You may also be eligible for this vaccine from the age of 50 if you are immunosuppressed. To help with the cost of prescriptions, you may benefit from purchasing a prepayment certificate. This is a certificate which allows you to obtain as many prescriptions as needed within a specific date range. The current cost of a 12-month certificate is £114.50. Here are a few helpful tips regarding your treatments. Remember that although we try to limit the amount of steroid we use, treatment with the DMARDs and biologics is long-term. It can be challenging to remember to take your medications, but in order for them to be effective, they need to be taken regularly. Using phone alarms and leaving your medications in a place that will remind you to take them are some ideas that might help with this. As with all medications, there are potential interactions with other drugs. It's therefore important that you let other healthcare professionals know which medications you are taking before you are prescribed new ones. That brings us to the end of this talk, where we've run through some of the commonly used medications in rheumatoid arthritis, including the DMARDs, and in case of more difficult to treat arthritis, the biologics. Thank you for your attention.